So what we're going to do, we're just going to discuss a little bit about the physiology about fetal and neonatal medicine, postnatal transition, and importantly, an example of what happens when it goes wrong, which is PPHN. Now, I know obviously discussing on a physiology on a sunny Tuesday morning can seem a little bit dry, so I hope everyone's had their caffeine this morning. But I do think this is absolutely critical to understand essentially what we do in neonatology, and obviously give all the neonates that we attend the birth of and see subsequently the best start in life. We know that the transitions generally are a pretty difficult thing for humans to deal with. That's in life, not just at birth. But certainly the structural and functional changes that go on at birth are unparalleled in terms of the magnitude of a human transition. And because they are so big, obviously they have the potential to go wrong. And it's important, I think, to understand what hopefully benefits the transition, i.e. what the fetus does to prepare for the transition to extrauterine life, and obviously how we can support that transition best. Sorry, this is just being very slow. Going to the next slide. Just wait for a second. Okay, there we are, eventually. Okay, so the learning objectives for this session is obviously understand the key differences between the fetal and neonatal life, and obviously understand the physiological transition that happens at birth. We're also going to touch at the very end just an example of PPHN in terms of when postnatal transition goes poorly and what we can do to manage that transition and support a baby through the transition. And obviously, for those of you who've managed PPHN, know that it can be quite scary. And obviously, we need to understand the physiology in terms of treating this baby correctly. Now, in a lightning learning session, and I've taken a few liberties with the slides, we're not going to be able to cover everything that we need to know. So I've just included a couple of suggested readings at the bottom of the screen. One in particularly is the best one is the Hillman et al. Review. So 2012, I know seems a lifetime ago, probably is most of your medical lives to a lot of you, but actually that's a great synopsis of what happens in fetal life, in neonatal life, and the transition. So a lot of the stuff that I've taken will obviously be quite high level, but obviously if you want a more detailed account of what happens, then please do go away and read that. It's incredibly useful. Okay. So with fetal physiology, essentially the transition to postnatal life affects every organ system, but there are three systems that I think have the biggest change affecting them. So the first is the heart and the cardiovascular system. And the things that are affected are blood flows, particularly as fetal shunt pathways change, myocardial maturation and performance, and obviously blood pressure and the effects on pulmonary blood flow. With the lungs, through the fetal life, the lungs develop, and we'll touch on that. They undergo changes in morphogenesis, surfactant production, and actually the fluid homeostasis. So the fluid within the airways and the fluid resorption is an absolutely critical element to being able to transition to postnatal life. And the endocrine factors are also pretty important. And these include energy metabolism, thermogenesis, and most of those, as well as the cardiovascular and pulmonary sequelae, are controlled under the influence of the primary mediators, which are cortisol and catecholamine production. Okay. So let's start with the stuff that you're probably going to be most familiar with. So the stuff that I think you'll be most familiar with is probably going to be the fetal physiology around the heart and the cardiovascular system and the changes that happen around birth. So fetal cardiovascular physiology. So obviously what happens is there is a maternal placenta in situ. Blood comes back from the baby, deoxygenated from the two uterine arteries, goes into a capillary bed with microvilli, where it flows fairly freely and actually has oxygen dissociating and nutrients across from the placenta. And this means although the mum's blood is well oxygenated, because there is mixing of the deoxygenated fetal blood with the oxygen coming from the maternal blood, you get an oxygen saturation of a maximum of about 70 to 80% that travels back to the fetus from the umbilical vein. As you will know, the umbilical vein heads towards the liver, where it then divides, with a branch going towards the portal vein, with the main branch becoming the ductus venosus, which goes towards the fetal heart, meeting with the IVC just as it crosses the diaphragm, and then heading into the right atrium. This blood is really clever. So obviously the blood from the umbilical vein is relatively well oxygenated. It has the highest oxygen percentage of any blood in the fetal system. And despite it mixing with the IVC, which has deoxygenated blood from the lower half of the fetus, the blood from the ductus venosus, high in oxygen, gets preferentially streamed across the foramen ovale and into the left atrium, the left ventricle, and then is pumped out to perfuse, is then pumped out to perfuse the brain and the upper body, making sure the brain and the upper body receives the most oxygen-rich blood. I know the screen sharing has just gone off for a second. Okay, so hopefully you can see that better now. Okay. There is deoxygenated blood, which arrives back to the right side of the heart. And that comes from the upper body via the SVC. And the more deoxygenated blood, that comes from the IVC. That goes to the right ventricle. And although it's pumped out into the pulmonary artery, only a tiny minority goes through to the lungs, about 10 to 20% initially, with the majority then going through the ductus arteriosus to join the descending aorta and perfuse the lower half of the fetal body. Now, there are a couple of really important principles here. So firstly, what happens is because only a tiny proportion of the blood flow goes to the lungs, there is high pulmonary vascular resistance. That's one of the reasons why it diverts down to the ductus arteriosus and goes to the aorta. The high pulmonary vascular resistance is essential for fetal life. And it happens because of the relative hypoxia of the fetal blood. It happens because the lungs are filled with fluid, and that itself actually overly distends the lungs, so actually gives less space and increased pressure in the pulmonary vasculature. And it because the hypoxia and the relatively low blood flow reduces the amount of prostaglandin I2 and nitric oxide that the fetus produces. So there are three main factors to vascular resistance really high. And because of that, blood with material oxygen tension about 60% or so heads down into the aorta, goes back perfuses the rest of the body, then goes back obviously to the placenta via the uterine artery, and the cycle starts again. What's also useful to know is that because so little blood comes back from the pulmonary veins, because the pulmonary perfusion is so small, and because about 25% of the blood in the right atrium gets across the foramen ovale, in utero, the right ventricle pumps a lot more blood than the left ventricle. So the right ventricle is said to be dominant, doing about 2/3 of the work of the heart in terms of the blood flow. And so we need to know, or we know that birth, that needs to change acutely to get from a parallel circuit to a series circuit where both ventricles are pumping equally. Now, the neonatal circulation is the right-hand side of the picture. It is very dim. You can see that it has the blue bits and pinks, i.e. now we are in a series circuit rather than a parallel circuit. And the main changes are the closures of the fetal pathways, which means that there is no longer any role for crossing the fossa ovalis, and blood going through the pulmonary artery then perfuses the lungs rather than getting shunted across the ductus arteriosus. And we'll come to those mechanisms in a minute, but just to say that is the transition that we're to achieve. If we go to the next slide. The changes in the lungs from fetal life are particularly important. And the changes in the lungs are really about three things: growth and emphasis. And you remember from the different fetal casts that you go through different lung phases. So the second and third trimester go through the canalicular phase, the saccular phase, and then the alveolar phase, which you only really reach a term, which is when you get a greatly increased surface area of the alveoli because you're making more and then they're differentiating their terminal buds. Okay. Now, as well as maturation, there are other key concepts going on, and one of them is the clearance of fluid from the lungs and the primitive airways. As the lungs develop, to actually get that normal morphogenesis, develop those alveoli, increase that surface area of the lung, you need active fluid, so extraction into those airways to create the pressure those lungs form. So the pulmonary epithelium will actually pump chloride into the airway space, which drags fluid into there, which means that those airways are full with fluid, which actually gives a descending pressure to cause the lung to grow. That's really important, but obviously as we transition towards birth, we know that all that fluid needs to be resorbed, and we'll come on to that in a second. The other thing with the lungs do is that as you head towards term, it begins roughly at the kind of midpoint of the second trimester, they start producing and secreting a little bit of surfactant into the fetal airways. And this surfactant is obviously the chemical that's going to lower surface tension of the alveolar, let them descend, and actually facilitate good gas transport, which leads to good oxygenation and ventilation. Those three factors are absolutely key. They're under the control of cortisol and catecholamines. And actually, as you go through your fetal life towards the third trimester, your cortisol amounts increase, increasing your catecholamine production, and cortisol and catecholamines help with your lung development, increase your surfactant production, and actually change that fluid process from a process of actual secretion into the airways into an active process of resorption. So you change from chloride secretion into the airways to sodium secretion into this interstitium to absorb that fluid back. So, as I said, when you go through fetal life and heading towards birth, three things you need to do for your lungs to work are to increase your surfactant production. And we know that babies in active labour, so fetus in active labour, actually significantly increase that surfactant production, a huge amount. We know that in labour, what happens is you not only squeeze a little bit of the fetal lung fluid out of those airways, but actually the chemical changes mediated by a huge rise in cortisol changes your ability to absorb fluid, particularly back into the lung interstitium, and this is mediated by the sodium channels. What that means is that if you have a preterm baby, with reduced surfactant production and who's not gone into active labour, then they will have both a surfactant deficiency and actually lots of fluid remaining in their airways, which means that oxygenation and ventilation, the removal of carbon dioxide, are both going to be significantly inhibited at the time of birth. And this is why pre-labour delivery, particularly by caesarean sections, is actually very, very challenging for the airway and for adaptation after birth. And this is why two of the things that we do in those scenarios is consider corticosteroid administration, glucocorticoid administration for mums, and also think about surfactant after delivery for the babies in order to actually try and achieve these two processes via different means. The other thing that needs to adapt for birth is the cardiac needs to become increasingly mature. So as you go through the late stages of fetal life, your myocardium matures, particularly the contractile apparatus, and the great vessels mature, so you get increased pulmonary blood flow, which increases your nitric oxide. And because of this, essentially, it reduces the pulmonary vascular resistance even before birth. And the last thing, as I said, the thing that mediates all of this is that you get endocrine activation. So particularly if you go into labour, you get a surge of cortisol and thyroid hormones. You get vastly increased beta receptor agonist, both sensitivity and stimulation, which is important because that also helps with your fluid resorption and primes your heart to be able to pump, particularly the left side, and slowly increases your systemic vascular resistance in preparation for birth. What this means is that we can identify the babies who are going to be at risk of poor transition. The babies who do not undergo labour, essentially they have reduced cortisol production, they have reduced surfactant production, they have reduced ability to resorb that free fluid, so the airway fluid, and they have reduced maturity of their cardiovascular axis, which means that babies who do not go into labour are at high risk of poor transition. We also know that babies born prematurely are at high risk because for the very same or very similar reasons, they've not had that cortisol surge that they need. They do actually have slightly raised catecholamine levels, which are improved, but they have got reduced receptor sensitivity to those catecholamines. And obviously they've got less ability to resorb that fluid from their airways. So via several different mechanisms, they have the same or slightly different processes, but the same end mechanisms going on. So to transition to birth, we said that we need three things to happen. We need the lungs to be cleared of fluid. We need the alveolar to be aerated. And we need to establish a functional residual capacity. And what happens at birth is that you'll notice that the baby often takes a big breath in. When they take their first breath, they create a substantial negative intrathoracic pressure. That helps drive the lung fluid out of the airways into the interstitium. And very quickly, all of that lung fluid, and within 2 to 3 breaths or so, most of that lung fluid has dissipated, meaning that air can get to those alveolar and can establish a functional residual capacity, which means that you can then start oxygenating and ventilating if you're a baby. And this is key. Now, if the baby doesn't breathe, that means that they don't establish any of those mechanisms. They don't clear their lung fluid, they don't aerate their alveolar, and they don't establish a functional residual capacity. And that's where our positive pressure inflation breaths can do that for them. And that is one of the reasons for supporting a baby's transition by giving a few big positive pressure inflation breaths, which maintain those three functions: the clearance of lung fluid, the alveolar aeration, and the establishment of that functional residual capacity. And the functional residual capacity is important because we know that stretching of those alveoli helps it increase surfactant production. So the more we get that FRC established, the more that surfactant will actually work in a positive feedback loop, allowing for further alveolar aeration, giving further surfactant. So that's absolutely key. So that is why lung inflation, either the baby doing it themselves by crying or with our positive pressure inflation breaths, is absolutely key. At the same time, you've got some quite significant cardiovascular changes going on. We'll talk about delayed cord clamping in a minute, but what happens at the time that that cord is clamped is that you get an acute rise in your systemic vascular resistance. You've removed that low resistance placental vascular bed, which means that your left side of the heart has to work against a significantly higher afterload. At the same time, if the baby is breathing, then as the baby aerates their lungs, as their oxygen tension improves, and actually as they reduce the overdistension by clearing the fluid, their pulmonary vascular resistance reduces. And again, you get a lovely positive feedback loop here, where if you aerate the lungs well and oxygen is absorbed, that reduces your pulmonary vascular resistance. You get more blood flow going to the lungs, which produces more nitric oxide, which then allows more oxygen to be collected from the lungs, which then obviously reduces that pulmonary vascular resistance further, establishing more pulmonary blood flow. So it's really important early on to try and establish that lovely positive feedback loop, aerate the lungs in order to oxygenate. And as these two things happen, as your systemic vascular resistance increases and your pulmonary vascular resistance falls, you will inevitably close those fetal shunt pathways. You get an increasing left-sided pressure, so your systemic vascular resistance, which means that blood no longer flows across the foramen ovale. If you transition successfully, by about 10 minutes of age, you should have at least bidirectional flow going across the ductus arteriosus before reversal of flow going from left to right if necessary. And that will lead to functional closure. And that closure is also mediated by a normal pH and good oxygen tension. So those are the three key processes. I'll just spend a little word here just on delayed cord clamping. Because in order for the heart and cardiovascular system to transition effectively, the first thing that needs to happen is your pulmonary vascular resistance needs to start to fall. If it doesn't, and if you're not getting good pulmonary blood flow, then if you clamp the cord prematurely before you've had a chance to aerate the lungs, then you will get an increase in your systemic vascular resistance before you've got any significant preload coming back into the left side of the heart. And that leads to left ventricular dysfunction, which means that you don't perfuse your organs and your tissues that well, which leads to acidosis and a negative feedback loop, because you'll get some anaerobic metabolism going on with increased acidosis, and therefore you'll increase your pulmonary vascular resistance. So the key here with delayed cord clamping is you delay the clamping of the cord until either the baby's had a cry and started to achieve some regular respiration, or until you've successfully started to aerate the lungs and given inflation breaths with kind of observed lung expansion, and then you'll know that the air is getting in, the oxygen is getting in, and at that point, then you can clamp the cord. As I said, the other thing to note is obviously what's going on with cortisol and the catecholamines, because not only does this particularly affect the two processes in the lungs and the heart, but these processes also control energy metabolism and thermogenesis. And we obviously know if you don't have good energy metabolism and thermogenesis, then both the heart and the lungs won't work well. For our preterm babies, essentially what that means is that we need to keep them warm, because we know that they don't have the brown tissue and they can't get decent thermogenesis. But also remembering about the glucose, remembering to give them early substrate is absolutely critical in terms of that transition. One thing that will help is actually early skin-to-skin contact, so giving mum a quick cuddle, because early studies have shown that actually that increases cortisol production, both in preterm babies and more specifically in term babies. So that can help normalize that process of transition at birth. And rather than overly medicalize a baby, if a baby no longer needs our active management in labour ward, we should be trying to get them for a maternal cuddle as soon as we possibly can. Okay. So I'm just going to spend a little bit of time now thinking about failure of transition, using particularly the example of persistent pulmonary hypertension of the newborn. And actually, oh, hello. Okay, so I'm just going to talk about PPHN a little bit. And the nice thing is that this is a condition which says exactly what it is. So the concept of PPHN is that you have persistent shunting of blood through the fetal shunt pathways because you have a persistently high pulmonary vascular resistance. And that pulmonary vascular resistance is often high due to poor oxygenation and goes hand in hand with poor pulmonary blood flow, which leads to reduced nitric oxide production, so endogenous nitric oxide production. Because you're getting poor oxygenation, you're actually getting tissue acidosis and anaerobic metabolism going on. And the failure to actually get good aeration to the lungs and the acidosis and the hypoxia that ensues often leads to reduced surfactant. And what happens then is you get this horrible negative, or the feedback loop. Again, it's a positive feedback loop, but from our point of view, one with very dire consequences. That as that process goes on, as you get reduced pulmonary blood flow, poor nitric oxide production, tissue acidosis, and surfactant deficiency, again, it goes to an increased pulmonary vascular resistance, which just worsens everything. So it is a cycle we need to break if we are to treat the baby. And in order to treat the baby, essentially the fundamental principle is we need to establish a systemic vascular resistance, which is greater than a pulmonary vascular resistance, so that our fetal shunt pathways are reversed and we actually send blood to the lungs to pick up oxygen. Now, what this means in terms of treatment is that we have a few clear strategies. The first aim of treatment should be that we should aim to try and, as much as possible, reduce the pulmonary vascular resistance. And there are several ways we can do this. Firstly, giving supplemental oxygen is absolutely key. So you need to maintain an arterial oxygen tension of about 8 to 11 kilopascals to actually allow that pulmonary vasculature to try and relax as much as possible and maintain aerobic perfusion and metabolism of the tissues. The other key thing to control is your ventilation. So this doesn't just mean maintaining a mean airway pressure, so your alveoli stay open and so you can oxygenate, but it also means removing carbon dioxide, because carbon dioxide is one of the other key factors that can increase pulmonary vascular resistance if there is a high CO2 level. So maintaining a PCO2 in the target range of 4.5 to 6 on our arterial sample is absolutely key to actually maintain ventilation and prevent further acidosis and increase pulmonary vascular resistance. To do both of these, then I think it's often a very good idea to consider and often give exogenous surfactant, because they will reduce the surface tension at the alveoli and they'll enable better ventilation. It's also a factor that a few of the conditions that cause PPHN, such as meconium aspiration syndrome and sepsis, they by their very nature have a reduced surfactant deficiency, surfactant production. We know that as well as oxygen, one of the most potent vasodilators for pulmonary circulation is nitric oxide. So we can consider and give inhaled nitric oxide just to try and relax that pulmonary vasculature further. And we also need to do things like keep the baby sedated and maintain ventilatory synchrony. So this is where we'll often give some morphine. Occasionally we'll give muscle relaxation to the baby if required. And we'll use ventilatory strategies which try and work with the baby, because dysynchronous breathing often increases your pulmonary vascular resistance further, as well as reducing your oxygenation and ventilation. So those are absolutely key concepts. And those are the things you should be thinking about anytime you see a baby with possible PPHN. Whilst you are doing those, you also need to do a second thing, which is increase your systemic vascular resistance. So as well as lowering the pulmonary vascular resistance by those mechanisms I've just outlined, you need to increase your systemic vascular resistance to drive that blood back, reverse those fetal shunt pathways. But we want to do this whilst maintaining a good cardiac output, and particularly a good left ventricular output. We know that some inotropes will actually just vasoconstrict, increasing afterload, and therefore reduce cardiac output. So we need a cocktail of inotropes here, which maintain the preload to the heart, both the left and the right ventricle, that increase contractility, but also increase systemic vascular resistance. And this is where it's beyond the scope of this talk, but this is where a knowledge of kind of inotrope management is absolutely key, because actually using the wrong inotropes can do the wrong thing. And by the wrong thing, I mean worsen cardiac output, increase systemic vascular resistance, but also do that at the expense of tissue perfusion. So doing things well is absolutely critical. And this is where, if you're lucky enough, skills in echocardiography can help look at those three factors, the preload, the contractility, and the afterload, and compare the systemic to the pulmonary vascular resistance in order to titrate the inotropes appropriately. The third thing, which should be obvious, is if there is a clear underlying cause, such as sepsis or pneumothorax, it's important to treat those. And it's also fundamental to monitor what you're doing with the baby. And this monitoring not only includes your normal SATs, both pre and post ductal, your heart rate, your ventilation with your parameters that you can look at ventilatory parameters such as your mean airway pressure and your tidal and minute volumes. But also I think it's an excellent idea in a severe PPHN to make sure that you have umbilical, venous and arterial lines, particularly so you can get accurate arterial blood gas sampling. So those would be the fundamentals of actually considering particularly a term baby with a failure of transition and supporting them through that transition. In the lesser cases, so if you think you have mild case of pulmonary hypertension, which you think might be transient, then some of the same fundamentals increase. Give them oxygen, maintain their functional residual capacity, and you can do that with PEEP. So if you see a baby in the labour ward, you're struggling a bit, grunting a little bit, maintain that PEEP for a long time, just to allow them to get that functional residual capacity, because that will help their surfactant production and get that lovely positive feedback loop of better oxygenation, better pulmonary blood flow, better oxygenation, better pulmonary blood flow, etc. Okay. Please do make sure with all times for these babies maintain normal temperature, because both hypothermia and hypothermia can both inhibit surfactant production, as well as changing the metabolic needs of the baby, and therefore can change your oxygenation and how you metabolize. So that's a lot of information. We've discussed a few of the key principles about fetal physiology, neonatal transition, and the failure of transition using the example of PPHN. There are a few key take-home messages, but actually what my main take-home message is that this is the stuff. Physiology doesn't change in terms of if you learn physiology once now, then it will stand you in good stead for your whole career, particularly if you're looking after neonatal babies. So do take the time to go away and read at least one of those synopsis papers that I talked about, and think about the physiology every time you go to a baby's delivery. Please remember that fetal physiology is very different from that of the neonate, and understanding the physiology is critical to neonatal management. With the transition that occurs from fetal to postnatal physiology, it's important to think about why babies might be at risk of suboptimal transition. And this might be because of a maternal illness. This might be because of a degree of prematurity. This might be because something suboptimal has happened in labour. This might also simply be because a baby has been delivered before they've gone through the process of labour, as we say, without the change in their the preparatory change from the transition from fetal physiology. Remember that there is a key interplay between respiratory and cardiovascular physiology. Ideally, establish lung aeration before supporting the cardiovascular physiology, because without good lung aeration, you won't establish that postnatal cardiac physiology that you want. And the other thing is to aid transition at birth, don't ever forget the glucose, because maintaining that normal energy requirement is absolutely key to both support the lungs and also support cardiac function. The last message from the talk: failure in transition is often predictable and it's logical, which means that if you can think about the physiology, your treatment strategies become obvious. However, these babies can actually go into negative cycles, negative feedback cycles very, very quickly, which means that you do need to rapidly identify the problems and treat them in order to prevent rapid deterioration. We have lots of therapies which can be our friends with this, but actually establishing the good practice early, good lung aeration, good oxygenation, they are your key facets and they will stand you in good stead. Okay. I'm not sure if anyone's got any questions with that. I'm just having a look at the chat function, but that's the end of the slides. So first, apologise for the sound difficulties with that. So I noticed a few quick questions. So Amber, I think you've got a few questions. Cord milking advised or not? So I normally say not. So if you can allow for delayed cord clamping, for me, the object of that is to actually get good lung inflation and aeration prior to clamping the cord. Now, quite often that's difficult for two reasons. Firstly, there might be a lot of stress around the delivery. And secondly, sometimes obviously just the physical barriers to actually doing good lung aeration whilst doing delayed cord clamping can be really tricky. I know that most places are looking about how to get shelves or cots or beds which can come into the maternal side. Delayed cord clamping is now something we should be doing uniformly. I think the evidence completely supports that. Cord milking for my process, no, not particularly. Essentially what you do then is you establish a greater preload in some ways, which is good, but until you aerate the lungs, you're still not going to have that flow back into that left side of the heart. So again, I would tend to do the other things first, get good lung aeration rather than cord milking. Sildenafil. Sildenafil, I think, is for a different process. So sildenafil, I think, is for established pulmonary hypertension, which is not your initial PPHN, not around the not around that acute phase. I think your mainstay from the pulmonary vasodilatation relaxation should be good oxygenation and the use of inhaled nitric oxide. I think if you do those, then sildenafil, whilst it is useful for pulmonary hypertension in a later stage, I don't think we should be using that for the acute neonatal, the PPHN that we see in the first 24 hours of life. If we do use sildenafil, then I think that goes under echocardiographic guidance, and also I would involve the cardiologist in that decision. And I say that's mostly for babies, we say for later pulmonary hypertension rather than initial PPHN, as I understand it. I am happy to put up the screen with the two links. So I said the main paper is the Hilton et al. Paper from 2012. I think that's a very good one. And I think Anna's already shared that link, which is fine. So let me just go back to the slide with the links, and then I will leave that on. If there are no further questions, then I think it's now about 10 past 10. So I'll stop the recording and we can leave it there.